patient, 14 years old, suffers from abdominal pain, increased thirst, and dehydration. She is on daily insulin injection because of type 1 diabetes discovered 2 years earlier. But she went for outing or somewhere with her friends and lost control because it's a big mistake she made. She did not confide in anybody that she has to take injections, which is a mistake actually. So she was hesitant to take injections, shared rooms, etc. Then fun and frolic, increase diet, less exercise, night overs, etc. So loss of control. After she returned home, she felt increased thirst and she had to wake up to urinate a number of times at night. That's what her mother noticed. And there was weakness, which they thought is because of tiredness, but then developed abdominal pain, which was getting severe, more and more severe. The skin was dry and wrinkled. She was taken to the local dispensary. A doctor did not have much facilities there, but he performed Benedict test, which came out to be positive, a brick red color. The doctor also performed with the limited facility Rothra test, which came out to be positive. The doctor correctly interpreted brick red color. So that means the blood glucose level must be high, in fact, very high, more than 180. We are going to see that. And he immediately referred to the teaching hospital because he feared that the patient will soon lapse into coma. He was getting unconscious. So a competent doctor lapsing let's into coma, into a comatose state. But before that, she could reach the teaching hospital. So 286 was found to be the blood glucose level. The young resident, a competent and confident, fortunately, he started insulin infusion immediately without and after collecting the blood sample without waiting for any further results. And the results came which authenticated his line of action. 286 था तो insulin तो चाहिए ही थी. The few hours After a few hours, pH was found to be low. PCO2 was paradoxically low. The patient was breathing heavily and deeply. So अभी हमने बात की थी कुसुमल breathing, which is washing off carbon dioxide. And I have not shown here, later the result came that bicarbonate concentration was also low. And serum potassium was quite high. Initially, it was more than 5.8 also. So hyperkalemia. How much is the normal level? 5.5. So initially, it was higher. This is after 24 hours. Let us say it was 6.5. So sodium and chloride, they were normal. So what is it? He started insulin infusion, which is very useful because insulin not only promotes entry of glucose into the cell, it also decreases serum potassium level. We are going to see why. And serum potassium hyperkalemia is very dangerous. So potassium monitoring is very important. Please remember my words when you see this patient. So now we come to some basic points. The dispensary में जो doctor था, he did a very wise thing performing Benedict test, and he found that the color was brick red, and it's a semi-quantitative test actually. When the concentration is 0.5 gram percent, then the color is green, 1% yellow, 1.5% orange, 2% red, and more than 2%, it is brick red. That's what the doctor detected. And he thought that the patient is having severe hyperglycemia. What a wise decision to do. And then Rothra test he performed. Rothra test is for ketone bodies. It detects only the true ketone bodies, acetoacetate and acetone. The third one can be detected by modified Rothra test. Please find out what is this modified Rothra test. So this is the third question I'm giving you. Explain basis of symptoms. Polyuria. The child was getting a number of times at night also to urinate. So why was that happening? Because all of you know glucose is filtered at the level of glomeruli and it is reabsorbed at the tubular lumen. Glucose tubular lumen में ये reabsorb होता है. When the level crosses 180, then the reabsorptive capacity of the tubule is exceeded because that is reflected by TM, tubular maximum absorption of glucose, और उसकी value है 320. Please check it. This is 320 milligram per minute. All right. Different books mention different, but 320, I will stick to this figure. If the value exceeds, I mean blood glucose zyada ho jayega, then more glucose is filtered, then can be reabsorbed, and glucose will find its way into the urine. And all of you know glucose is highly hydrophilic, highly polar. So it carries water also along with it. और उससे फिर क्या होगा? Water भी चला गया. तो उससे फिर ये जो हमने अभी बात की थी द polyuria. So glucose excessive carrying water also. So polyuria. Polydipsia. You see the patient develops dehydration. You all know about from your physiology. Thirst centers will be stimulated. Polydipsia. प्यास बहुत लगेगी. Kusum wall breathing we have already seen. Two, it's a compensatory mechanism so that bicarbonate concentration also falls and pH is restored. Explain the basis of lab reports. Glucosuria, I have talked about it. Renal threshold 180, 320. I have talked about it. So glucosuria ka ho gaya. Ketonemia, ketonuria, we have already discussed because of three steps: increased free fatty acid, acetyl coenzyme A, which are channelized into ketone bodies production. Outline dangers of ketosis. I think for descriptive purposes, the first one is dehydration. That is the first one. Second one is hyperkalemia. It can cause sudden cardiac arrest. Third one is relating to sodium. Sodium is also called buffer cation. So sodium क्यों जाएगा? This is a PG level thing, but still, you know, if you find it interesting. So glucose, क्या होगा? Sorry, it's taking time. Yeah. Sodium, you know, acetoacetate, acetic acid, it will dissociate into H plus and acetoacetate, which will complex with sodium. So what is being filtered? Sodium acetoacetate. And then there are reabsorptive mechanisms for sodium absorption. But now when excess of acetoacetate is being produced, सोडियम को ये अपने साथ लेकर जा रहे हैं. More sodium is filtered than can be reabsorbed. तो उससे फिर क्या होगा? More sodium is getting filtered than being reabsorbed. तो उससे क्या होगा? Sodium depletion will be there. But if you remember, lab report में हमने देखा था sodium concentration is normal. I'm going to give a difficult statement. Try to decipher it. Sodium content in the body will decrease, but the concentration will not. The reason is that sodium ka loss, it's an isotonic loss. Sodium carries water also along with it. So there is no hyponatremia, although sodium is also lost. और क्या था? Outline dangers हमने तीन बता दिए, तीन डिस्कस कर लिए. Other causes of coma: hyperosmolar non-ketotic coma. This happens in type 2 diabetes. Type 1 diabetes में ketoacidosis होता है, type 2 में नहीं. Another question for you: what is ketosis resistant diabetes. And then the patient with type 2 diabetes, they often take biguanides, oral hypoglycemic. इनके अंदर लैक्टिक एसिडोसिस का रिस्क बहुत ज्यादा रहता है. वो क्यों रहता है? प्लीज ट्राई टू फाइंड आउट. तो मैनेजमेंट, insulin infusion with potassium monitoring. Potassium monitoring is important. तो हम एक थोड़ा सा देख लेते हैं, इसको थोड़ा एलोबरेट कर देते हैं. पोटेशियम लेवल rises, but why? So there are three reasons. I'm going to be more detailed about it now. What is role of sodium potassium pump? It pumps potassium inside the cell in exchange for sodium which it pumps outside the cell. और ये pump है क्या? It's an enzyme, and all of you know that the enzymes function maximally at 7.4 plus minus 0.5. और इस पेशेंट में कितना था? 7.2 था. तो 7.2 pH पर enzymatic activity will decrease. In other words, sodium pump becomes sluggish, ineffective, less effective at a lower pH. So potassium influx into the cell will be hampered. As a result, serum potassium level will increase. So that is the first reason, sodium potassium pump. The pump activity falls. Second, insulin directly opens certain potassium channels and promotes entry of potassium. तो इंसुलिन कम है, नहीं है, तो वो भी हो जाएगा. Potassium will not be able to enter the cell through these channels and its serum level will increase. Third point, H plus concentration has increased. So antiport mechanism, H plus will go inside the cell and in exchange for potassium. So antiport mechanism involving potassium and H plus. The first one, antiport mechanism involving sodium and potassium. The second one, uniport. Insulin directly promotes entry of the. So last point, potassium monitoring is very important. Saline drip is given to the patient and the rate of infusion is determined by not by glucose concentration, by the electrolyte concentration, potassium particularly. So thanks a lot. Thanks a lot, Dr. Adelbert also for helping me with this.